Good afternoon, everybody. We can get the members to take their seats. I appreciate everybody being here. We have actually went from not having a quorum to having way over quorum. We have a busy schedule as it gets closer to crossover day. And let me tell the members, please, all the members, listen up. We will be meeting on Monday, probably around 3:30 or as soon as we get through with session. That is in order for some of the members that have bills. If we meet on Wednesday, that puts us in a really tight place to getting bills out and getting them on the calendar before crossover day. So we're going to meet on Monday, and I will need for you to be here. There will be some important bills coming up then. I have two bills, and since my vice chair has to leave, I am going to go first, which I normally wouldn't do, and I'm going to turn it over to my vice chairman.
Thank you, Madam Chair, members of the committee. We're going to start today with House Bill 303, sponsored by Chairwoman Cooper. Representative Cooper, whenever you're ready.
See if the switch is on the mic itself.
William, is it on? Thank you. I think I'm on. I wouldn't want anybody, and there is a sign-up sheet here. If anybody wants to talk on any of the bills, I will put it here on the corner. I want everybody to know that this is a very historic day, and that House Bill 303 is a very historic bill. For the first time since I can remember, and this is my 15th year, the nurses, the PAs, and the Medical Association have agreed on a bill. So, and this is what this is. 303 is their compromise. Of course, some people want more, and that's not included in the bill. But what this does, very simply, allows our nurse practitioners and our PAs to sign certain forms, to do certain physicals under their protocols. And their, I think the PAs call it something else besides a protocol. The PAs call it a job description. The nurses call it a protocol. And under their protocols to do different physicals and that relate, and to sign the forms for them. And also, it changes the way that they have to sign out or account for samples that they use in the office with the physician. Used to they had to lock them out. It was a very cumbersome situation, and now they will just note in the patient's chart the samples that they give the patients. I'll be glad to answer any questions. And I will tell the committee and tell everybody else that our freshman, Jason Shaw, did have a request from a nurse practitioner that became very involved in his election. They were unable to do physicals for our sheriffs, and this will allow them to do it. And Jason was nice enough to allow me to enclose that and let this one bill cover that. And Dr. Watson was nice enough to take his name off this bill and let me put Jason Shaw's name on it, which will go out on the website so his people will know that he was working hard for them and that he got it for his nurses. So thank you very much, Representative Watson.
Thank you, Madam Chairwoman. Any questions from members of the committee? I see none. I will entertain a motion to pass at this time.
Certainly, Mr. Chairman, we have to thank the author for her great work on this bill and bringing it forth. You do a great job for Georgia. And I make a motion that we do pass.
And what bill do you have that you want on the schedule for Monday? I haven't seen that yet, Representative Mitchell, but, you know, bring...
We've got a motion from Representative Mitchell and a second from Representative Chokas. Any discussion? Boy, I love these kind of bills. All in favor signify by saying aye. Aye. Those opposed, like sign. Thank you.
Thank you very much.
Next.
I stand corrected.
Thank you. The next bill that will be presented for members of the committee is House Bill 343, That is by Chairwoman Cooper and others. And Madam Chairwoman, whenever you're ready.
Thank you, Mr. Chairman. When I first came to Georgia, I had student nurses that went to Milledgeville, where I was teaching psychiatric nursing. And the hospital in Milledgeville had 12,000 patients. And it was a hospital that was built for 5. And the ladies on the ladies unit walked around with their belongings in little plastic bags because they didn't have anywhere else to put them. But they were taken care of. They did get medications. They didn't freeze to death. And they were not on the street. At that time, President Jimmy Carter decided that we should change Georgia's care of mentally ill patients to model Texas. And unfortunately, it was a good idea because Texas had some community health centers, and that was what we were going to do. But we let people out of the state hospital before any of those community health centers were built. So a large portion of our homeless are the people that would have been in Milledgeville if we were still caring for them in the same way. Instead, they're on the street, they're mentally ill, they freeze to death in the winter, the women are raped. It's a really terrible situation. I am so glad that I have finally come and lived long enough to see Georgia begin to really do what is right for our mentally ill citizens. I'm sorry that it took the feds coming in and telling us to do it, but I really don't care because we are now doing it. We now have a department devoted to these patients, and we are beginning to move the legislation that is going to set up a continuum of care that tries to keep and tries to intervene when people are first in crisis and keep them out of our state hospitals. It is a continuum, and today this bill deals with one portion of that continuum. It is sort of up close to the hospitals. It's the crisis stabilization units, and they are sort of the place when you go when on an outpatient basis and case management hadn't worked and intervention hadn't worked in the community. They are temporary, short-term inpatient facilities where they can try to stabilize patients and try to keep them becoming sicker to where they would have to go into one of our state hospitals. There is a lot of misinformation out there about it. We are not closing all of our state hospitals. We are decreasing the number because we do want to meet people out of the big hospitals and to keep them in their communities. And to do that, we have to set up a system where they get early intervention and care. So with that, I would like to ask Dr. Shep, who is the commissioner of our mental health department, to come up and anybody he wants to bring, and he can answer any specific questions that the committee wants to ask. Let's go. They'll turn the mic on for you.
Thank you so much, Madam Chair. I'd like the members of the committee to recognize the hard work put in by Chairwoman Cooper on this, as well as her co-sponsors, the governor's floor leaders, and Representative Houston, who chairs the Appropriations Subcommittee dealing with the appropriation of this particular subject matter. Welcome, Dr. Shep. Any questions from members of the committee? We'll hear your comments now then, sir.
All right. We already operate a number of crisis stabilization units. Their origin goes back to a letter of agreement some 10 years ago between the former Department of Human Resources, the Georgia Hospital Association, and the Department of Community Health. And so today we have 16, I think, such units. In that letter of agreement, they were the exclusive franchise of the community service boards. And their function was mostly aspirational at the time. But now we have some 10 years of experience, and we understand both the limitations and the potential for the use of these units. What they do is they provide for emergency receiving and evaluation levels of care for involuntary individuals under our 1013, the involuntary civil statutes, to go to a place where they can receive 24/7 care, be evaluated by a physician, receive nursing care, medication, etc. And and be close in proximity to the community from which they come, which also facilitates their return to that community. It also shortens the amount of transportation time, which also shortens the amount of time that a sheriff has to travel. And so we have worked together, both with the Community Service Board Association and others, to put forward this bill which would codify the existence of these units in law rather than in an agreement which, at least in part, is to an agency that no longer exists. And the Community Service Board Association, I would point out, was willing to accept losing the exclusivity of their franchise around these units, allowing the department to completely manage them, and if necessary, find other management for these units should they not be able to achieve our levels of service and expectation. So without much further ado, I'm going to pretty much leave it at that unless there are further questions.
That's a great job. Anybody else would like to speak on the bill? Any questions of Dr. Shep? Great. Todd, thank you so much for your comments. Todd Citron. Good afternoon.
Thank you. My name is Todd Citron, the Executive Director and CEO of the Cobb and Douglas Community Service Boards, and I'm here representing the CSB Association today. There are 25 community service boards throughout Georgia, and I chair the Executive Directors Group. By June 1st of 2011, CSBs will operate 18 out of the 20 crisis stabilization units for adults and 3 of the 4 for children and adolescents. Representative Cooper has visited our unit in Cobb. It is a 16-bed unit, 70 admissions per month, average length of stay of 5 days. Our association supports passage of House Bill 343. DBHD presently certifies the CSPs every 2 years. They have a survey team that consists of 4 RNs and 1 LPC. Our association asks that the Health and Human Services Committee act favorably on 343. Any questions?
Thank you so much. Next, we have Frank Berry.
Good afternoon. Madam Chair, thank you for the opportunity to speak, and distinguished members of the committee, thank you very much. I am Frank Berry. I'm the Executive Director of the GRN Community Service Board. We believe that people with behavioral health care needs can and do thrive in the community and lead lives of recovery. We believe that people get better have better behavioral health outcomes when they are treated closer to home. Crisis stabilization programs are a key component to serving people effectively in the community. It is a part of a comprehensive community-based service array. While not the highest level of care, CSPs are instrumental in keeping people closer to home and connected to the services that they will need. The average length of stay for people in a crisis stabilization program is 5 days. CSPs help avoid the need for more expensive and more restrictive levels of care by alleviating the backups that we've been experiencing in our emergency departments. The majority of our consumers that come to our crisis stabilization programs come from the emergency departments. GRN operates 2 crisis stabilization programs, a 16-bed unit for adults that has been in existence for over 12 years, and a 27-bed unit for adolescents. I can tell you this, that the mother that I met with last week at our crisis stabilization program for children was very pleased that she was able to get to and from the facility within a matter of minutes to be able to visit her child. That was extremely reassuring to her that she could show up at any time and see her child. CSPs are instrumental in relieving the emergency rooms and the unnecessary burdens that the emergency departments are faced with. GRN supports this bill. This bill continues to support the vision of one state behavioral health authority, which is the Department of Behavioral Health and Developmental Disabilities. Thank you for your support of this bill.
Ellen Yeager. Good afternoon. Is the J silent?
Well, it depends on whether you like Jägermeisters or not.
I'm not even going there. So for half of us up here, it is silent. Good.
Yeah.
Thank you for letting me speak this afternoon. I want you to know that I'm Ellen Yeager, and I represent Mental Health America of Georgia, and we do support this bill. We're anxious to work with the department. They know of the few concerns we have, like the reimbursement rates, and we know that they're looking forward to working with the community at large and making sure that the CSUs are certainly units of quality. But we do support this. We think it's really important, and actually it would be impossible to close some of the hospitals if these units didn't exist. So thank you very much.
Any questions for the author from members of the committee? Representative Chanel, did you want to be recognized, Mr. Chairman? Yes.
Madam Chairman, is there any restrictions on the size of these units? I mean, it doesn't, by bed size or anything like that?
The size of these is targeted at 16 beds, and that is not something that is in statute, but is under rules and standards, which the department administers. I would ask that that be left in rules and standards within the department, because this number is tagged to CMS, the Center for Medicaid and Medicare Services, regulations that define an institution of mental disease currently as a facility of more than 16 beds. Should they make that more restrictive or slightly more expansive or flex with that, we would want to be able to respond without statute. But the department's commitment is to continue to target them for 16 beds, and this allows us to bill Medicaid for services that Medicaid will allow for.
I mean, I want to be clear, I wasn't advocating that it be a size restriction. I just noticed it's exempt from CON, and I was just curious as to what size these units are going to be.
All right, they are targeted at 16, as Todd Citron mentioned with his Cobb Douglas unit.
Thank you.
Thank you, Chairman Chanel. Representative Hudson.
I have somewhat a similar question to Mr. Chanel's. I'm interested in these units too, and I appreciate the author for bringing this legislation. I think it's badly needed. How many of these facilities do you foresee?
What did we tell the DOJ that we would do?
We're anticipating 4 more.
4 more?
Yeah, that's what we anticipate, but reminding us that we already operate 16 adult and 4 child, so 4
That's
more
what you currently have.
currently, and then 4 additional is what's in the immediate future.
Okay.
These units are flexible enough that as population expands or other things happen, we'll be able to meet need. But 4 is all that is anticipated.
And one more question, if you
Please.
don't mind. And Chairman Cooper knows my healthcare background. I come from a healthcare family. What types of people would operate places like this? Would they be licensed nursing home administrators, hospital administrators? What kinds of folks would operate these places?
Well, we anticipate that community service boards will continue to be the most successful at operating these.
Okay.
But the legislation does not bind the department to community service boards. But we anticipate that they would continue to be the overwhelming representative, doing this. But should another party want to compete for the management of this, we would look for someone with similar experience to a community service board executive or someone with appropriate management credentials.
Okay, thank you.
If I can add and let Todd Citron from Cobb, I think we run one of the best ones.
Okay.
Brag a little bit on my community. We
Yeah.
don't always do everything best, but our CSB is really quite wonderful and serves a huge community need. What kind of people, Todd?
The vast majority of the folks who come into crisis stabilization, and I'll speak for Cobb and Douglas counties, are coming out of the local emergency rooms. So it's people who kind of crash land in an emergency room, substance abuse, or a mental health crisis, and usually require a stabilization period. The mix of diagnosis on our unit is 53% substance abuse, 47% mental health, and sometimes you have co-occurring issues where they have an addiction and a mental illness. And it is, you know, they've kind of hit wit's end. They've failed an outpatient, or they've not received any care, any therapy services, and they land in the emergency room. It can be 24 hours a day, 7 days a week. These units are very busy. They stay full. There is a demand for more of these units. When my unit is full, folks can be referred to the state hospital. That's why the expansion of the crisis stabilization units. So they're critical community service. Also, in regards to the use of law enforcement to do the transportation, if my crisis stabilization unit is full, folks would have to be transported up to Rome. Thus, with the closure of the state hospital, the need for expanding those units. But it keeps law enforcement from having to transport all the way to Rome in Cobb County, and keeps folks local 15 minutes from the local emergency rooms. But I would say of the 70 admissions we have per month, that probably almost all of those come from either Cobb or Douglas County emergency rooms or other emergency rooms in the local area.
But what kind of people do you hire?
I've got a very experienced full-time psychiatrist who oversees all the care. We have a clinical nurse specialist who is the director of the program, and it is staffed. The staffing is very good. We maintain security staff from the hours of 7 p.m. to 7 a.m. We meet this staffing ratio. It's a 1:8 nursing to client staffing ratio. We've got 2 registered nurses on during the daytime hours, and an RN and an LPN who serve from 7 p.m. to 7 a.m. We have, with a census of 16, we routinely staff 4 staff in direct care during the day, and then we have social workers and then some other management staff. And then in the evening we have 4 staff members, and we also have a security guard. So in my opinion, they're staffed quite well. So.
Representative Fullerton.
Thank you, Mr. Chairman. I have a couple of questions. What is the geographic spread of these community service boards that have these units?
Well, I would preface this by saying that geographic spread can refer to land or to population or to both.
To the areas of Georgia.
Right. Well, within Georgia, you have both of those. You have land and population. So in the metropolitan areas, you certainly have more. And when you go out into the lower populated, more rural areas, you have less. So I would have to say the best answer is that it's proportionate to the need.
Do we have any areas that don't, any major, any of the 7? Don't we have the state broken up into 6 or 7 areas?
We have divided the state into 6 regions for the purpose of organization. And the new units, 3 of them are targeted for the northern region 1. And the 4th unit, here's my map. This isn't the best map. These aren't jumping out at me from this map.
What about in the southern part of the state, south of Macon?
I know that we have a child unit in Chatham County, and I know Albany River Edge has several. Middle Georgia has one. Pinelands, Gateway, Satilla. Yeah, I'm trying to match them by South Georgia, though. Let's see, I know that Pineland is in the south, and LaGrange, Gateway, Savannah, Albany, I think I mentioned Macon, and Waycross.
We can get that list distributed at a later date.
Yeah,
where,
you want to follow up?
Yeah, thank you. Where there are not units that are provided already that are on your list, are there local hospitals that hospitals just take care of those if they have a psych unit or some sort of?
The state psychiatric hospital system continues to serve individuals of similar kinds of needs. And in addition, as it was mentioned, I think, by Representative Cooper in the very beginning, that this is part of a continuum.
Right.
So we are seeking to engage general hospitals in the proximity as well to be part of that continuum. So this is not the sole solution here. This is one component that sits right below hospital in the continuum of care.
Thank you so much. All right, what's the pleasure of the committee? Got a motion to pass? Got a second? Any discussion?
Yes, I'd like to offer an amendment.
All right.
And I think this amendment would sort of add to, and Representative Fullerton, it is on page 1, on line 14. After you say, it says operated, you would strike as a part of a comprehensive community mental health and substance abuse program. So you would start on line 14 after operated and strike as a part of a comprehensive community mental health and substance abuse program. And then you would strike on the second page, 28. Starting on line 28, you would strike that entire mention of the comprehensive mental health unit, and on line 29, program, and reorder accordingly. What that does, Representative Fullerton and members of the committee, it opens it up so that it is not just our CSBs that already have the units. It opens it up if your local hospital wants to start a crisis stabilization unit, they can do so. So that amendment opens it wider. This is just a beginning. It is what we are able to do with the funds that we have, but I would say that there's a vision of having more than the other 4 that they're talking about now, but to reach out to all areas of Georgia and try to keep our citizens as close to home as they possibly be, and to keep them out of the state hospitals and out of our general hospitals, the ones that are not capable of taking care of them and have to hold them in their emergency room because there's a lack of beds. But it's a beginning. It is the beginning of a whole new comprehensive Georgia program to take care of our mentally ill patients. And if any good comes out of the feds having to come down on you, we could be a leader with what we are instituting as a model for the rest of the United States and the care of the mentally ill.
You were this close to getting out of there. Representative Fullerton.
I just want to say thank you. I've worked in the mental health and addictive diseases area for 30 years or so, and I'm very pleased that we're moving in this direction and that you've taken the leadership to get us this far.
Representative Fuller, I can't take credit for that. We have great people in our new department. I mean, it's been a collaboration of us and the legislature being willing to start the new department, to break it out from Representative Chanel breaking the departments up last time. If we're going to really do a good job of taking care of the mentally ill people of our citizens of our state, it is going to have to be all of us working together, and we play a part. So I am just a small part. I'm very concerned about this, my background, and I just think this is a great day for Georgians. Thank you.
Thank you.
We've got a motion on an amendment. Do we have a second on that? Any discussion? All those in favor of the amendment will signify by saying aye. Aye. Those opposed, like sign. Amendment approves. Got a motion on House Bill 343 as amended. Got a second? All those in favor signify by saying aye. Aye. Those opposed? House Bill 343 as amended is passed committee. I need to do a little housekeeping. It's been brought to my attention that the previous vote that we took unanimously on House Bill 303 was actually presented as a committee sub. We didn't get that language in, so at this time, Representative Mitchell, I'll let you move again. And I'll second it take a second from Representative Chokas. All those in favor of passing House Bill 303 as a committee sub signify by saying aye. Aye. Opposed, like sign. House Bill 303 passes as committee sub.
Thank you, Representative Reinders. We did pass that last one as amended, didn't we? Okay. just checking. My able-bodied vice chair, thank you very much for helping me out and for all your work on appropriations. We have a couple of other housekeeping. I sort of joked with Representative Watson last time about the first time that I'd ever had a bill sent back from Rules to Health. Now it's back for the second time. It was an error, and the new amendments did not go over. The bill has not changed any. I just need a motion to move the substitute to House Bill 227 to be passed again, and so we can send the right forms with it. 147. Okay, I have a motion. Do I hear a second? Okay, I have a motion and a second. Is there any discussion?
Madam Chair?
Yes?
I just want to make sure nothing's changed. We're doing a technical adjustment.
We're doing a technical adjustment. What
Thank you.
happened is that the copies 1 and 2 of the amendment did not travel to the clerk's office last time, and the only way to change that, just so it'll be a learning experience for everybody, is for the bill to be sent back to committee, re-voted on, and sent back again. So here we go, Representative Watson. Okay. Hearing no further discussion, everybody in favor of the substitute to House Bill 147, say aye. Aye. Anyone opposed? No. Okay, we have 1 no. The ayes have it. Thank you, and we will make sure the correct forms go with it this time. Okay, Representative Clark, second bill to come back to my committee. This is House Bill 227. I will say this is not Representative Clark's problem. We had some members in Judiciary that were not doing their job ahead of time. And they came up, and it got to the floor, and they came up with a suggestion. So will you tell us what has been added to your bill?
Thank you, Madam Chairman. There's only just a slight little change here that just says in Section 2D, it says any school personnel who in good faith administers, or, these are the words we added, or chooses not to administer epinephrine. So the only change is or chooses not to. You want to make sure that the teacher has immunity all the way around. So we've just a slight little change, so that a teacher could administer EpiPen to a child who's in anaphylactic shock.
So basically, what it means is that if a teacher in a crisis situation has a child going into anaphylactic shock and decides not to administer an EpiPen, they cannot be held liable for not administering the EpiPen.
Yes, correct.
That's it. Okay, Representative Reiner.
Thank you, Madam Chair. I recommend do pass.
Okay, we've got a do pass and a second. Is there any further discussion? No discussion, then everyone in favor to the substitute to House Bill 227, say aye. Aye. Anyone opposed, no? No. The ayes have it. Okay, thank you. Okay, what's the next one? I don't have a, do you have a schedule? Yes, ma'am. Okay, what have we got? Okay, I'd like to call Representative for House Bill 275, Representative Chokas.
Thank you, Madam Chair, members of the committee. Today I bring forth to you a committee sub to House Bill 275. House Bill 275 is not a very sexy subject, but is something that's necessary when we're dealing with the end-of-life stage. And it was brought to me by Julie Herring, a nurse in my district, and the purpose of this bill, if you'll notice in your packet, and I can read what the problem is. Under current law, the Department of Community Health has determined that nurses and medical assistants, caregivers working in personal care homes, nursing homes, must administer CPR regardless of the presence of a physician's order not to resuscitate. This decision is contrary to the patient's rights protected by the not to resuscitate order, and is also inconsistent with other medical personnel that are currently authorized to follow the DNR order. Currently, nurses working for a hospital, professional care officials, and EMTs are authorized to follow the order. Under DCH's interpretation of the current law, nurses and healthcare professionals working for personal care homes are not authorized to follow a valid DNR order. What we've done in this legislation, Madam Chair and members of the committee, is to expand the authority so that it would include nurses and caregivers to the list of persons authorized to follow DNR orders, and to clarify that these healthcare professionals can follow the orders whether they work in a hospital or other licensed facility. Also included all licensed medical facilities, authorized medical personnel, and the limited immunity provisions for making those decisions for CPR. I had a great deal of support when I went to members of this committee on the House floor. I had over 21 signatures to House Bill 275. As I said, it brings dignity to the individual that has chosen to have a do not resuscitate order. The reason for the committee sub is because after I dropped the bill, physician's assistants wanted to be included as those listed that were able to carry out the do not resuscitate order. In your packet, you see a letter requesting that they be added to this legislation, and a letter in the letter it shows their support for this legislation. At this time, I can answer questions, or I can go down section by section. I hope that everyone has had an opportunity to review it. Review this legislation, and as I said, we're just allowing human dignity for the end-of-life stage.
Okay, and we have questions. Representative Jurgensen.
Yes, sir.
Thank you, Madam Chair. I actually have a question for our learned counsel in the back. Madam Chair, if you remember, a couple years ago we had a pretty extensive do not resuscitate bill that I carried, and I don't, Betsy, if you were, and I know we're like 2 or 3 years ago, we went through the forms, we went through secondary physicians' signatures and nursing homes and those facilities. How would this bill dovetail into what that bill was that's now law?
Well, it certainly wouldn't change anything that was changed in that bill. So it just expands it in these certain areas to the PAs, nurses, and caregivers, but it doesn't affect the two signature process that you're talking about that was implemented.
We changed the form in that legislation, so do we now have 2 different forms in?
No.
So this would change the form that we changed a couple years ago?
You're saying the form is a codified form?
Yes, ma'am.
The form is actually on page 3. I think that's what you're talking about. So it does actually change language on line 86. Is that the form you're talking about?
Yes, ma'am.
So it does impact it to that extent.
Okay, thank you.
I just want to make sure that this is as tight as it can possibly be. Are we talking about the caregiver within a certain health type of facility? We may have someone at home who perceives themselves to be the caregiver of their husband, their spouse, whatever. I just...
The definition on page 1, lines 10 through 13, cross-references another code section that has very specific requirements on what those two entities are, the proxy caregiver giving health maintenance activities and the person performing auxiliary services. So that's those provisions are very tight and cross-referenced here. So it wouldn't cover what you're talking about.
So you don't think there's any potential, just like we did on the bill earlier, any potential liability issues with someone who did or did not do it as a caregiver at someone's home?
No, I don't think they would come under this definition.
Thank you.
Okay, Representative Watson.
Just a point of clarification. I believe that the home DNR, is, as I believe it's called, is an orange form and is unrelated to that. That's just a point of clarification, I think.
Thank you. Representative Jurgensen.
Thank you, Madam Chair. I'm sorry, this one kind of caught me off guard, so I'm just kind of looking at it from the beginning. There actually is there kind of is some substantial changes in the DNR order. If you look at line 76, we're changing this from shall to may. That means that the patient may or may not have a bracelet that indicates a do not resuscitate order. I think that's a very serious change, especially in certain settings.
I'll let Representative Chokas speak to that, and I think it's in response to the patients.
I'm glad you brought that question up. It's a very good question. The patients are reluctant to wear the bracelets because it separates them from the rest of the other patients, and they feel uncomfortable with it, and it was a matter of human dignity. And as I said, the nurse, Julie Harry, brought that to our attention. And at that point in time, when someone very soberly signs a do not resuscitate order, I don't think we should make it unduly embarrassing on the part of the patients. And as I said, that was one of the requests that Julie had in this legislation.
I respectfully understand that, but in discussions that we've had in the past, not you and I, but in the discussion with the last DNR form change, there was great concern to that point, because what happens in a facility if resuscitation begins on a patient that has a DNR, and what kind of issues are we opening the door to between the family and that potential facility? Or in a hospital setting, there may be personnel that are not aware, and that's the whole reason for the bracelet, is that it's clear indication that that patient does not wish to have resuscitation done to them, and it is done. If that patient's not wearing a bracelet, what are we dealing with? That was a major concern in the past.
And I appreciate that. From what I understand, and Madam Chair, if you could help me with this, from what I understand, the orders not to resuscitate are distributed to all those involved with the patient.
That is true, but this, again, going back to the reason that it's in this particular form, is because there are circumstances in a life-threatening situation when somebody codes that those forms may or may not be thoroughly looked at initially. And that was the reason that it was put into this form to begin with. And so I would respectfully ask that you consider that, and that was thoroughly vetted in committee when we did this before.
Excuse me, Representative Jurgensen, if you want to make that as an amendment, you certainly offer it to the committee. I think one of the problems is that it being of an orange background, and it's pretty obvious that some of the ladies feel like it's.
And I don't have a problem with the orange background, but there needs to be, in my humble opinion, there needs to be some type of secondary measure there. Because, I mean, we want to be, I think everybody in the committee certainly wants to respect a patient's wishes and give them that dignity in the end-of-life situation. And the last thing that we want to do is do something that is completely contrary to their wishes. And this was a secondary measure to ensure that that did not happen.
In Representative Jurgensen, I respect your opinion and appreciate from which you're coming forth, but this was at the request of patients. Nurse Julie Harry has been dealing in nursing homes and assisted living facilities. This was not something that she just made up and thought would be easy. It was after having many consultations with the patients and finding that they really disliked wearing those bracelets, or at least wearing the orange bracelets. So that was the impetus for the change. Those that choose to wear the bracelet are still allowed to wear the bracelet. It's just that those that choose not, and this is an individual decision and a difficult decision, that those that choose not to wear the bracelet, we're not going to force them to wear this bracelet. And so that's the impetus. It's not saying that they can't wear the bracelet. If they choose to do so as an added precaution, they most certainly can. It's just that I feel that at that point, and having signed such a sobering document, that we shouldn't say, if you don't sign it, if you do sign it, you got to wear this bracelet. We should leave it open, an option for the patient.
And I understand that. I'd like to hear from some of the associations and their opinion on, specifically the nursing home and hospital associations and what their opinion is on this.
Let me go through the people.
I'm sorry.
I'm glad to let them do that. Let me go through the rest of the questions from the committee.
Yes, ma'am.
That's all right?
Well, I had a letter of support, I think, from the nursing homes, if I'm not mistaken.
Okay. Representative Watson.
Just a point of clarification. We're the only place we're talking about the shall and may being changed this is only in patients who are, and correct me if I'm wrong, but this is only in patients who are not in the hospital, not in the nursing home, or not in a licensed hospice. This is a person who is, I guess we can read, that is in a personal care home or assisted living facility or in their own home or their own apartment. So we're talking about not making those patients wear a bracelet. Is that correct?
What line are you on, sir?
We're on line 76, page 3. Starts on line 75. Is that? I'm just. That's what it looks like to me. But let's see. But with the patient, yeah, that would go with them. I see what you're saying.
If I may, the whole point, he is correct. The whole point is EMS arrives at the home and they don't have a bracelet on their wrist. What do? That is the whole point of it. And again, that was thoroughly vetted when we did this form.
Representative Jurgensen, thank you very much. I think you probably have amendment percolating in your head. Okay. Maybe it's the orange color that is so offensive. Pardon? Red and black? It sort of hurt my heart to say that the orange color was offensive. Maybe if you put it with orange and white, it would have been better. So, okay, Representative Reinders.
Thank you, Madam Chair. I'm really just trying to wrap my mind around my good friend Representative Jurgensen's thought process, and I appreciate what does EMS do when they show up. But I would think that individual freedom trumps everything we do in this country. And if someone says, I don't want to wear something, I'm just trying to figure out the role of government says, no, you will. I'm having a hard time with that. Can I ask them to respond to that?
Certainly.
Whether or
with
not
the exception being prison outfits.
Oh.
Well, that's true. And I agree.
Which are orange,
Yeah.
maybe.
No, Representative, I appreciate that, and I agree with you 110%. Remember, we're talking about what's in the DNR form. Whether or not they wear the bracelet or not, that's certainly an individual freedom. But the form here.
Doesn't the form say shall wear it?
But if somebody's not going to wear it, they're not going to wear it.
But
that's
just
their choice. But we're saying what should be in the form. And
okay.
What are you, 20? What number are you? What number are you?
17. Oh, yes. We're on.
Ooh, a little number.
Yes, it is. Okay, again, my husband operates a nursing home and been around healthcare all my life. Anytime a patient's transferred to help somebody's feelings here, all of those DNR, all of those things are transferred with the patient when they go to the hospital or when they go to any other health facility. To let the receiving facility know that what's going on, because they have all that on file.
Okay, Representative Fullerton. Do you have a question?
Yes, ma'am. I wanted to respond a little bit to Representative Jurgensen's thoughts and what you have proposed here. My mother-in-law was ill with Alzheimer's for 7.5 years. And the last, when she was at home, my father-in-law tried to get her one of those bracelets to wear so that in case she got lost, people would know where to send her or who to call. And she would not wear that bracelet. And she got to the point where we thought she was going to make sores on her arm. And we finally took it off. And it just wasn't worth it. And she was in an institution, assisted living facility with an Alzheimer's unit for the last 3 months. And it wasn't worth it. It just wasn't going to happen, which was kind of unusual because she always wore bracelets when she was well. My father-in-law was in the same facility in an apartment for 2.5 years. He had a DNR. And he coded, and they called my husband and asked if he wanted to come get him or to have the EMRs brought. And they called the EMS folks, and they got there. And the nurse had the file on top of him as he went out of the facility, and he was not breathing. And the nurse kept emphasizing, he has a DNR, he has a DNR. But as we all know, EMS's job is to keep them breathing till they get them to the hospital. That particular time, he came back and lived another year very well. And he was very glad they did that. It's so hard to fine-tune it to take all those things into consideration. Sometimes we just have to count on having good healthcare professionals and families taking care of us.
Thank you. Representative Kaiser. Okay, Representative Henson.
Thank you. As I've listened to this, it looks like there seems to be such an incredible concern here that we don't miss a single solitary person in this law. I mean, in the fact of a person who doesn't want to wear the bracelet, there's always going to be people missed. And, I'm not addressing the good or bad of it, but I think when we pass a law, we hope that it pertains. If there's some folks, this is permissive in terms of the bracelet. If it wants to be worn, then more than folks really know. And if someone doesn't, if we didn't pass this law, they wouldn't be wearing the bracelet. And as I see that we're just trying to help more people, but there is absolutely nothing we can do that is going to address every single person with their situation all the time. Otherwise, we'd be a big brother society out there. Ooh. So we do our we would be if we were telling everyone what they had to do. I'm not advocating for it. I'm just saying we do our very best in trying to pass things and hope that it does address the people that we're aiming it at. So, I couldn't support something that told people they had to.
Representative Byrd, you want me to let you go before Representative Holt? Representative Byrd, go ahead.
I'm trying to breathe heavy right now. Sorry. Catch my breath.
Representative Byrd, Holt, I'll get you right after her.
Like to know, how does one know who not to resuscitate, and is this not a liability for EMS? If an EMS shows up your home, what do they do if you have chosen not to wear your bracelet, if he does not know about your DNR form? I'm concerned, and I am all about small government.
Thank you.
No kidding.
Thank you, Representative. Representative Byrd, thank you. Under Section 5, this clarifies the criminal and civil immunity for a good faith decision relating to the CPR, and that the presence or absence of a DNR order applies to nurses, caregivers, licensed professionals such as nursing homes, licensed facilities such as nursing homes. Persons and entities already covered by these immunity provisions are physicians, healthcare professionals, healthcare facilities, EMTs, and their agents and employees. So I appreciate that question, and it is addressed in Section 5.
So Representative Holt. Oh, you've got another one? Representative Byrd? Do you have another? Okay, Representative Holt.
Thank you, Madam Chair. The foregoing discussion may have answered my question, but just to throw it out there, and this is something I don't know if Representative Jurgensen can address or perhaps counsel, but yeah, this whole question of having the shall versus changing it to a may, is there already something in the existing statute on this that would hold harmless a responder who arrived at, say, a home, performed resuscitation, and there was no bracelet? Is that what's in here in Section 5?
In Section 5, yes, sir.
Okay. Then that answers my question. Thank you.
Thank you.
All right. Okay, there's no further questions. Representative Reiners.
Madam Chair, I make a recommendation to pass.
Okay, I have a motion and a second on the substitute to House Bill 275. Further discussion, Representative Jurgensen.
Thank you, Madam Chair. I really think we're kind of missing the point in the whole discussion about liability or I mean, that's clear in Section 5, I think. The point is this is a one-time decision. You can't go back and undo it. And for a DNR
yes, you
type
can, from what I understand.
not when a person has passed away.
Oh, well.
It's a one-shot deal.
But, I mean, if you change your mind before
if you can do that, then we need to have another discussion.
We need a bill for that.
The point is we're talking about the DNR form itself. It's the form. And when we talk about this situation, we're not talking about people in hospitals. We're not talking about people already in nursing homes. Representative Hudson, absolutely, those files transfer with the person. What we're talking with is a person who has made a conscious decision that they do not want to be resuscitated, period. And this gives the responding caregiver or EMS or whoever it might be that goes to that home the ability to know, without having to look in a medical chart, what that person's wishes were. Now, if they choose not to wear the band, that is completely their decision. But in the form itself, the reason that shall is in there is to say, under the prevailing context of how we do DNRs in this state, this is what the normal practice is. So when the EMS person or the caregiver walks in the door, they may or may not know. And when we're talking about, and I guess I would have to ask each and every committee member here, put yourself in that situation. If your neighbor, your friend, that you think may or may not have a DNR order, and you walk in and you're the person that's dealing with this situation, and you do or you do not resuscitate them, and it's contrary to what their wishes are, what's that going to make you feel? How's that going to make you feel? What's that relationship going to be in the future? I think this is one small step within the form, and I know it's a minor point, but to me it's a major point because I dealt with it in those previous bills. It's not hurting any type of situation by having it in the form. That's what we're talking about, in the form, not whether or not we're making somebody do something. And so I would respectfully ask that you support an amendment, and I'll go ahead and make that amendment, Madam Chair, that we strike the may in line 76 and unstrike the shall and leave that as it is in the current code, in the current representative form that we have.
Okay. We have an amendment. Got a second on it? Okay, we have an amendment and a second. I just have some. Okay, I got it. It's just to go back to the shall instead of the may, and omit the may. Got it. But we have people that, I have some discussion on it. Representative Watson.
Thank you very much. Back in a previous life, I was a hospice medical director for about 12 years, and this was about 20 years ago. And my recollection is that there was an issue, and I also was an EMT about 30 years ago. But that was an issue as an EMT or for bystanders in people's homes, whether or not they were DNRs or not. And because it was obvious to an EMT when you walk into a home and the patient's cachectic or dying from cancer, and they certainly would not want to perform CPR on that person. But they did feel obligated, by law at the time, and that was an issue. But it is from my recollection, and I need some clarification because I thought this was still ongoing, that there is an orange form that is a home DNR that sits by that bed in the house that is easily recognizable by the EMTs. And that's why I need some clarification because is that not ongoing now?
Do you know of any form like that?
Because I certainly wouldn't want to put a bracelet on someone that we got an orange form that says that is a home DNR order that is there. That may be in place.
The hospice will require the form. Representative Hudson said if they are covered by hospice that the form is required. I know that it is in Tennessee. With my mother there, she did have a form, and let me tell you, everybody in the world knew that she did not want to be resuscitated, and it was there by her bedside. I don't know about the orange form, and Betsy, can you?
I don't know of it in statute.
We don't think it's in statute. Representative Henson.
I guess I'm still having a problem with the word shall. I know it's been in there, but we're going back to it, and we're heightening the awareness of this, and we're going to have people that are going to say, oh, you have to wear this or you're breaking the law. I know there's no penalties for not wearing it, but I think that it should be may.
I think we're going to get to vote on that, Representative Henson. Will that be okay?
Yes.
Representative Holt.
And again, once more, someone discussed my question just before me. My point was there's no penalty attached to this shall. Is that correct? Right.
No,
okay.
It's not on the form.
So it's there.
Separate.
It's a strong exhortation to the patient to wear the bracelet, but they can choose not to wear it, and they're not punished. And we're not going to try to punish them.
Legislative Council says it is not on the form.
Well, the form is technically on line 66 to 74. That's the form. So if you fill out that form, then the next code section or subsection saying you have to wear the bracelet indicating you filled out the form above. And then below there on 81 to 85 is the language that has to be on the bracelet or necklace if you fill out the form.
Right.
Okay. But it's not actually a form. Representative Clark.
My question was, if you don't have a bracelet, would valuable time not be lost looking for that DNR order? Now, if there is a bright orange sign, then that answers my question. But if there's not, I'm wondering, would an EMT, as he's, I'm thinking myself responding and I'm panicking. Well, I'm not panicking. I'm an EMT.
Hopefully not.
Hopefully I'm not. Critical.
Well, I know you have trouble with the EpiPen, so
right.
Okay.
Would valuable time be lost and maybe the person then is dying and maybe they don't have a DNR as I'm looking for that evidence to support me not.
I think to answer your question, and I appreciate you asking that question, having lived through an experience with my father and him having a do not resuscitate order, we wouldn't have called the EMTs. And that's why I'm a little bit concerned about the what if scenario. But if the family and the people in the nursing home are all aware of that, why would they call the EMTs?
And just to clarify that, when you have hospice, when the patient dies, you don't call the EMTs.
You don't do that.
You call hospice first, and hospice is who takes care of things.
So I appreciate you asking that question, and I was hoping that Representative Jurgensen, you could see that that is part of the human dignity aspect that I was bringing to everyone's attention, and that I was hoping to be able to solve that issue with the patients.
Representative Reinders.
Thank you, Madam Chair. You told a heartfelt story, but till you walked in those shoes, when that 88-year-old mother of yours looks at you and says, please don't make me wear this. I mean, when you're talking about the dignity of life, that they're looking forward to the nightly ice cream, and all they're asking you for anymore is don't make me wear this. I just don't think that's the right thing to do. I'd like to call the question, Madam Chair.
Well, I'm taking two more questions because
Okay.
they're on the list. Representative Kaiser.
Thank you, Madam Chairwoman. I actually originally wasn't going to speak to this, and I'm not still quite sure how I feel about the shell with the bracelet, but I just want to make two comments for thought. One is when my father passed away, I think the worst thing that could have happened is that he would have been resuscitated on all machines when we got there. Secondly, one of my former legislative aides had a mother resuscitated, and it was really devastating. And there was a DNR on her mother, and I went to the nursing home with her, and they couldn't produce it anywhere in the file. So it's just food for thought.
Thank you.
Representative Watson, you get the last.
You know, if there is not an orange home DNR order for non-hospice patients that are living at home, maybe that would be something that would be more acceptable. I'm just throwing that out for thought also.
Betsy, can you help Representative Watson do a quick amendment? I mean, would that be, if they had the orange with you, I mean, if it was still may wear an identifying bracelet, okay, and then also unless they're posted or something, do you need a long time to do it? Or just a second? Okay, we'll stand. Okay, Representative Jurgensen. She's working on it.
Thank you. Yes, my whole point is that there needs to be some type of secondary identification. And to Representative Reinder's point, I did lose my grandfather in August, and we went through this exact situation with him. So I have walked in those shoes. And he was out of it enough that it wasn't an issue with him. But we brought him home for the last 2 weeks of his life, so I have been there recently. And my whole point with this, and I hope it doesn't seem frivolous, and I certainly respect the dignity of all of our elderly patients and non-elderly patients. But the point is, Representative, we need a secondary, because not everybody has their family around them. Not everybody has those types of situations. And if we're going to have it, then we need to make sure that we are covering it as well as we can. And I think Representative Watson's idea is a very good one. And if we can craft that where it is making people aware when they walk into that situation that, hang on a second.
I think that our legislative council, who were working to death and couldn't do without, Betsy has an amendment ready.
This is kind of roughed out, but on line 77, after the word necklace, we would add to the end of that sentence, or may post or place a prominent notice in such person's home. And then down on 78, at the sentence that starts, the bracelet or necklace, we would revise that to say the bracelet, necklace, or notice shall provide the following information, so it'll have the same content. And then the same thing on line 87, such a bracelet, necklace, or notice.
Betsy, at the very beginning of that, when you said they may, I think what we are wanting it to be, or what at least Representative Jurgensen's amendment would be, with that they shall.
Okay, so do the original may on 76 and then do a shall.
Post a notice.
Okay. Do I need anybody to have Legislative Council read that again? Are we okay with it?
I'll modify my amendment to that language.
Okay. All right. We have a motion and a second. Any discussion on Legislative Council's and Representative Jurgensen's amendment that will require that they either wear a bracelet or, that they don't wear the bracelet, then they're going to have to post in a prominent place.
I'm sorry?
In a prominent. Okay. All right. Everybody in favor, say aye. Aye. Anyone opposed, no? No. Okay. The ayes have it. It is amended. Okay. We have a motion and a second on the bill. Everyone in favor of the substitute to House Bill 275 as amended, say aye. Aye. Anyone opposed? No. The ayes have it. The substitute to House Bill 275 as amended is passed.
Thank you, Madam Chair, and members of the committee.
Thank you very much. You're welcome. Let's see. I don't think Representative Neal's here yet. Oh, okay. Representative Neal.
Thank you, Madam Chair. I'll bring you House Bill 324. House Bill 324 is a bill in response to it's a request of the department in response to the settlement agreement with the United States Department of Justice and the Americans with Disabilities Act case against the state. As a result of that settlement, the state of Georgia will cease their temporary and immediate care admissions in hospitals effective July 1st of this year. This bill will make the law consistent with the settlement requirement with the Department of Justice. The settlement agreement requires that we take our best efforts to change the law to match the settlement agreement with the department. Hospital emergency room visits have been decreasing and will continue to decrease, and eventually those hospital admissions effective July 1 will be eliminated completely in the state of Georgia. There are several things that will take place that will benefit the state. One is hospital emergency room visits will decrease with the community-based crisis services for individuals with developmental disabilities that are being established. Sheriffs will no longer need to transport individuals with developmental disabilities who are in crisis to state hospitals, and that winding down of the temporary and immediate care or TIC admissions has already begun with strengthened collaboration among regions and community providers to manage crisis situations in the communities more aggressively. In fiscal year 09, there were 242 admissions. In fiscal year 10, there were 132 admissions, and in the first half of 11, only 59 admissions in the state of Georgia. The department is assuring enhanced behavioral, medical, nursing supports to enable individuals with developmental disabilities to continue living in the community. There are newly developed clinical and operational standards for the Georgia Crisis Response System for individuals with developmental disabilities will govern crisis intake, mobile crisis teams, in-home and out-of-home crisis support services statewide. There's a major statewide campaign to provide outreach, training, and education for all providers and community stakeholders to implement these changes. And let me just quickly point out in the bill where these changes, primary changes, are taking place. There are several places in the bill where you see some definition or title changes taking place, but the repeals in House Bill 324 are in Section 3 relating to the general provisions relative to procedures for obtaining services from the department, and in Section 5 related to the temporary and immediate care admissions to state hospitals. And rather than trying to give you any more information about the bill at this point, if the chairman would like, I will allow for questions. Dr. Shelp is here with the department that can help with answering some questions as well.
Okay, questions for the representative? No questions. Okay. Any questions for Dr. Shipp? Okay. I know that we have some concern, Dr. Shipp, and I was brought an amendment because there are some people feel that the definition of developmental disability is lacking. Why don't I let Josh Norris speak to that, and then you can respond. Mr. Norris, if you will tell the committee who you're with.
Thank you, Chairman Cooper. My name is Josh Norris. I'm with the Georgia Advocacy Office. We are the statewide protection and advocacy system for people with disabilities in the state of Georgia. What that means is we are a private nonprofit that operates under a series of federal statutes and federal funding that mandate that we advocate on behalf of people with disabilities throughout the state of Georgia. And part of our concern is that the definition of a developmental disability that is contained in Title 37 is causing a problem. At the federal level, in the federal definitions that govern Medicaid and Medicaid services, that definition includes not only people with intellectual disabilities, but it also includes people with physical disabilities who are significantly impaired in adaptive behavior. This means things like daily life skills, self-care, communication, mobility, ability to learn. The kinds of folks that fall into that category are folks with cerebral palsy, autism, Asperger's, traumatic brain injuries. And what's happened is that the definition of a developmental disability that's currently in our code under Title 37, which was created as part of House Bill or Senate Bill 228 that created the Department of Behavioral Health. That definition requires that a person have an intellectual disability or an intellectual disability and a physical disability. Bottom line is you have to have an intellectual disability. The problem with that is for all those people I just talked about that might have significant impairment in adaptive behavior, they would be excluded. Now, those folks can currently be served in our state hospitals. They can be served in our nursing facilities. But if we maintain this definition, they would not be able to be served by our waiver because that's the definition the department is enforcing. So what we are seeking in is amendment to that definition such that the definition would include both persons with intellectual disabilities as well as persons with physical disabilities who are significantly impaired in their adaptive behavior. And Madam Chair, we brought some documents or a single piece of paper with proposed amendments on it, and we had 30 copies. I'm not...
There.
Okay.
I think she's getting them out right now.
I'd be happy to take any questions about that because the practical implications are this. I know of two situations now where folks are at Central State Hospital. They have developmental disabilities. They are admitted into a developmental disability facility, yet they've both been told you are not eligible for a DD waiver because of this definition. This is going to create a problem with trying to comply with the U.S. Department of Justice settlement. The second situation I know of are kids who have become adults. They were in DFACS custody. They were living in well-supported community situations. There was an attempt to try and transition to adult DD services through the waiver. Literally, there would be no change for the person. They'd be living in the same place. But because the definition was used to say that they are not eligible, those folks are now in peril of potentially being at risk of institutionalization. There are many other folks in a similar boat. And lastly, the sort of rising problem we've got, and the much bigger problem in some ways, is that there are a number of folks who are currently served by our waiver, hundreds of them probably, throughout the state, that if this definition were applied to them today, would no longer be eligible for services, which would cause a tremendous disruption And so what we're trying to do is address this issue. We've been working with the department to try and come to an understanding of the problem and the issue. But I think we're at a point where we're seeking a legislative solution in trying to amend that definition. Any questions?
Okay, Dr. Shep. I mean, we don't want to do anything to hamper the...
I would simply say this bill is not about our waiver services. This is not even about the definition of developmental disabilities. This is about a commitment to not admit people with developmental disabilities, by whatever definition, to our hospitals, but to provide crisis respite and other kinds of services. So it's not related, this bill is not related to waiver services. A discussion of definitions and waiver services we're glad to have. We have ongoing. Those definitions are largely driven by the Centers for Medicaid and Medicare Services, and our waiver services with their current definition are compliant with that, but that is not the subject matter of this bill. These temporary and immediate care for people with developmental disabilities admissions, as Representative Neal said, is low. It is a small portion of our overall activity. It's less than 200 a year. And so I would like this bill to be seen simply at face value and supported to allow us to move forward for those services and not expand this into a broader discussion of waiver services and definitions.
Well, Dr. Shep, and I can understand that, and I mean, I do want the bill to move forward, but I think it does raise an issue that does needs to be discussed. I mean, we're just going through it with DCH and the bill I have in judiciary, because sometimes the lobbyists and the advocates for the disabled feel like that they're not heard, and I think that's been one of the problems in where is the correct place for this to be discussed and with whom, so that these people are not left out without the services and the waivers that they need.
All right. Well, this is somewhat taking me by surprise because there's a little different twist to how this was presented just now to how this has historically been presented. The definition of the area that this department is charged to serve fully accounts for mental health conditions, addictive diseases, and developmental disabilities that in many areas is referred to as intellectual disabilities. So this is the first time that this issue has been presented in my hearing to be about behavioral disturbances. And earlier today, in a different conversation in Representative Houston's office, this was also brought up in a different framework. What the department does not want to do is to interfere with waiver services that exist within DCH for those individuals who have disabilities from birth that would be developmental, but that do not include an intellectual or a mental health or a mental kind of disability. A purely physical disability is not the responsibility of the department currently, but it resides in the Department of Community Health if it is an exclusively physical disability. Now, if the discussion is now moving to other areas that are contained within the Diagnostic and Statistical Manual, which covers developmental disabilities and mental health diagnoses, then that discussion certainly we're open to and can have. But the focus of the department is to remain around those conditions that are described in the Diagnostic and Statistical Manual, which would include those kinds of conditions like Asperger's or other kinds of maladaptive mental health / developmental disability kinds of conditions. We're unaware, I am unaware, and have just checked with my staff, I'm unaware of anyone currently at Central State Hospital in developmental disabilities who does not qualify, who does not meet criteria for waiver services under our developmental disabilities.
Okay. Mr. Norris, in response, I mean, do you think we need to take this up as another issue with DCH? Now, we do have a new commissioner over there.
Yeah. This is not a DCH issue, I'm afraid. We've raised this issue over a number of months. This is not just my organization. There are a bunch of sister organizations, the Georgia DD Council, Institute on Human Development and Disability at the University of Georgia, Center on Leadership and Disability at Georgia State. This is a core issue of how we think about, define, and support people with developmental disabilities. It is well established in the field that developmental disabilities goes well beyond intellectual disabilities. It's not just about IQ. This is recognized long ago. And so the federal definitions that govern services under Medicaid, because that's the primary means by which we pay for all of this, encompass that. They talk about people with cerebral palsy. Those folks are not going to have necessarily intellectual disabilities, but they have substantial impairment in a variety of major life activities that impair their ability to independently function. And as a result, they are eligible to receive the same types of supports and services that a person with an intellectual disability would receive. And the only, Madam Chair, the only reason I think we have to bring this up now is we are well into the session. These kind of issues get dropped unless we bring it now and move it.
Okay, I'm going to exercise the right of the chair. If the committee will allow me to suspend discussion on this, I'm going to ask Dr. Shep, will you make sure that you discuss with Mr. Norris, and if we need to bring the governor's office in, and I'll be glad to attend those discussions, and we will meet again on Monday. And we need to get this resolved one way or the other so that the committee and that I can feel secure about moving forward. Is there anybody in opposition to me exercising the chair's prerogative on that? We're meeting Monday afternoon as soon as we get through, and whatever happens, that will give the bill plenty of time to move forward. Representative Neal, you okay with that? You don't have to come and present it again. We just need to clear up.
Madam Chair, I would prefer to see it move, but if you feel we need to do that, I'm okay with it.
And this is an issue I think we do. I'm hearing from the disability community. I just need to feel secure about that. Thank you. Okay, thanks to the committee for holding with me. We have one more. Bill, let me call Representative Martin. We're going to go over this so we can have so Monday's meeting does not go long. For members of the committee, I think you will remember last year we had quite a heated discussion about nursing homes and the non-existent assisted living level and trying to find a compromise so that we don't have people who can just live in residences where they don't need any help before they need to go to the nursing home, and that in-between place where they need a little bit. It was very heated. And I want to thank where are they? The people, there you are. Jason is short of hair over this issue, and from Fran Mangieri, they have discussed this. They have come up with a compromise. Believe it or not, we have another first. Here again, is it perfect? Does it include everything that I would like for it to include? No. But if it should pass, it would be a first step. There is a bill moving in the Senate. The Senate has been a little unusual this year, and we were just a little afraid to not introduce the bill here and have it ready to go in case something bogs down over there, because this discussion has been going on now for 16 years. And the people who first started it, many of them are in need of this in-between services. And by the time we get through, we probably will. And Jason's going to have to go early because we've driven him crazy. Or I guess he'll need Dr. Shep's, the crisis intervention centers, That's perhaps it. But I do want to thank y'all for working on it. I know that there's been a lot of discussion. So I just wanted the bill to be presented because I was afraid we have a time bind, and then we'll see what's happening on Monday and how far the bill's progressed in the Senate, and we may move it on out to the rules if we need to. Okay, Representative Martin.
Chairman Cooper, you acknowledged, I don't want this to seem like it was the Oscars on Sunday and thank all the same people that you thank, but I would just do that. I actually brought, that's one of the 3 folders that we had last year working toward this legislation, so I do appreciate everyone that's worked on it. I bring to you today a substitute to House Bill 405. It's LC 334114S. You should all have that in the packet. And by explanation, Madam Chair, this is the actual exact language of the bill that is traveling in the Senate. We have gone to great lengths to try to work with the parties involved in the compromise language. I got a little antsy, if you will, to move it, as you said, and went ahead and introduced language that we had, I think, version 9 of the compromise as of Friday afternoon. There were some small tweaks that were done to that, but in the interest of keeping the exact compromise together, I bring to you 405, which would mirror exactly if you did a red line to Senate Bill 178, I believe, if everyone has that. Madam Chair, I'll walk through the bill and do it quickly or to what level of detail you would allow. But Section 1 of the bill is the operative section where the compromise has been reached. This is basically what sets up and defines assisted living care, assisted living community at the bottom of page 1. Something that the committee will remember was a conversation piece last year has been the centerpiece of some negotiation and work. A term is being defined. It's used in other states, assisted self-preservation, to help us define what needs to happen for a non-ambulatory individual because we are concerned with their safety. So we refer to assisted self-preservation. We have the definitions further of continuous medical or nursing care on page 2.
In real basic understanding, I have been living independently, whether in my home or in a facility for senior citizens. Okay?
Yes, ma'am.
What does this bill, how does this bill differ? What does it allow me to do? What progression have I gotten in being less able to take care of myself without having to go to a nursing home?
Yeah, yes, ma'am. That is defined on page 1, lines 19 through 24. Actually, 19 through 26. Basically, this allows you to do all the things you can do currently in a personal care home, but it allows for additional medication to be given you in an assisted living facility that can't be done today in a personal care, under a personal care license, and it allows you to stay in a licensed assisted living facility if you are capable of assisted self-preservation.
Which means?
That basically means you are able to, with the help of staff, you yourself or with the help of staff, even if you are non-ambulatory, if you have to get around with the aid of a chair, assisted self-preservation means with the aid of that chair, with the aid of a staff person, you can be evacuated to a place of safety as defined by the fire marshal in the event of an emergency. So it's imperative that you can be and are capable of assisted self-preservation. Currently, in a personal care home, if you're non-ambulatory, even if you could get to a place of safety, you can't stay without going through several bureaucratic hoops. So this is a consumer-friendly bill, allows people to age in place, but it's first and foremost preservation of their safety.
And that's basically what it does?
Well, that's basically what we allow. The medical definition of what the medical aid can provide had not been allowed previously. That is defined in lines 103 through 112 of the bill to allow them to provide some services that aren't provided currently in the personal care home. It basically is just a step. If you remember last year me describing 2 licensure categories, a personal care home and a skilled nursing home, this being a third licensure category, this is what this creates, and we've done it with the collaboration of professionals from both sides, including the state ombudsman, who is can today or at a later time weigh in on the bill to make sure Seniors are being taken care of. We've created an opportunity for our seniors in Georgia to age in place. Probably, as the chair said, haven't done everything that one day might want to be done, but this is certainly a gracious and great first step.
Okay. Representative.
I was just going to, the rest of the sections of the bill are cross-references. I do need to say, Madam Chair, and I mentioned to you this, when we brought the bill previously, I had said that we weren't going to affect personal care homes at all, and we weren't going to affect skilled nursing homes. Based in the compromise language, which is what I was asked to bring to you, there is a section 13 that does touch into the personal care code. I just want the committee to understand that differs from what I represented to the committee last year. I just want to point that out. I leave that. That is compromise language that has been worked on by, I just want to be upfront with the committee, because previously I had related to the committee that we weren't changing at all personal care and nursing homes. This has a slight change there. The state ombudsman has weighed in on that it is a compromise language. With that, Madam Chair, the rest of the sections of the bill just seek to add assisted living definition to all those portions that personal care and nursing are added now, such that the state ombudsman will be notified. Basically, if there are cross-references to our Georgia code.
Okay. Questions? Representative Chanel.
Representative Martin, you've referenced compromise reached 2 or 3 different times in your opening remarks. Compromise between who?
The communities, Chairman Chanel, on the assisted living, what is called assisted living now, but is licensed as personal care, the operators of those facilities that have been involved, some operators of the Georgia, I think it's the Georgia Health Care Association, people that represent folks that are in the skilled nursing business and personal care homes, have worked together on this language.
So the nursing home folks and the assisted living folks have come together. Is that what you're saying?
Yes, sir. And we're expecting the second coming tomorrow too, I believe. But yes,
Okay.
sir, they have done that.
It is truly a historic day, Chairman Chanel. I mean, after 16 years, maybe this is a new beginning in Georgia.
No,
I don't know.
Madam Chair, I shouldn't make light of that. It's a very serious subject. Both parties, both of those industries are very concerned with the patient well-being.
Okay.
There's just been a place in the past where they haven't been able to get together, and they should be complimented for their work together. I don't make light of it at all.
No, I can't tell them how much I appreciate the fact that the two groups got together and worked on this for the betterment of Georgia seniors. Representative Hudson.
Absolutely. I did ask you a lot of questions last year.
Yes,
You
ma'am.
remember now. People that have personal care homes now, and if they want to meet the language of this new thing, would that be a new application, or are they just grandfathered in some kind of way, or what?
There would be a new licensure
A new
process,
license.
and we've left that in language to be defined and work through the department. I mean, among things, they have to, employ a medical aid. They have to make sure that they can provide for assisted self-preservation. And just to be clear from the committee, that new licensure process, we fully intend the department to write those regs and those fees to be self-funding. We don't expect that the state would come out of pocket to do that, even the licensure for the medical aids. Thank you for the question.
One more question.
Yes, ma'am.
That medical aid person that you're talking about, was that possibly the legislation of Mr. Pruitt's last year? Okay. So that would cover that unlicensed person to be able to give those meds?
Yes, ma'am.
So, other questions? Okay. All right, sorry. Representative Clark.
Someone who owns a personal care home at this time, are they able to care for a related individual in their personal care home?
I must apologize to the committee. I do not know that. I don't know that they're precluded from doing that, but they may in fact be.
You mean related to them? To get money? Right. To get money.
I'm told, Representative Clark, and I apologize for not knowing the answer, but
Do
I'm
we have
told by
somebody?
someone that you cannot, in fact, take someone in your family into a home for compensation.
Do you have an answer to that question? you know why? Okay. Virginia Clark.
The reason why I ask is I know someone personally who's in the process, and I need to follow up with them and see where they're at. They are almost move-in ready, and part of the the reason for building this and all was to take care of a relative. Right. So I'm not sure if they're aware of that or not, but I'm wondering why. But
Mr., can you talk to
thank you,
Mr. Neff, please, and that'll take care of it. Okay. Jason?
Thank you, Madam Chair, members of the committee. My name is Jason Bros. I represent the Georgia Healthcare Association. We represent 95% of the state's nursing long-term care facilities. We represent some assisted living as well, which is now personal care home. We also represent Source, which is a home and community-based service. And I just want to thank the committee for hearing the bill. And I'm definitely not the brains of the operation. So if anybody has any questions, I'll direct them towards Rich. If anybody has any questions about any of the bill or.
And Rich, you are?
Rich, oh, I'm sorry.
Rich Gardner with Arnold Golden Gregory to help kind of get this.
Ooh, the new lawyer. I like you better than the one last year already.
I'm much better. Thank you.
Would you like to add anything to this?
I would say that
for the freshmen who weren't here, they had sort of an aggressive lawyer last year that thought we were trying to hurt patients, and it didn't go well with us, especially with me. No,
well, I was here for that, and I've learned what not to do. So. I would say that some of the things that this does is it does create hopefully a solution to some of the issues with the distinctions between nursing home and personal care homes, and some of that has to do with the ability to keep ambulatory residents in a personal care home. I think that's the biggest issue. A lot of that's tied to two things: the certificate of need law, and then also life safety code. Our life safety code regulations in Georgia, not to disparage them, but they're extremely convoluted, and they cross-reference several volumes of nationally published regulations and model codes. And the issue is that personal care homes, we don't have anything but personal care homes in Georgia, and so they kind of get all assisted living facilities get lumped into that category. Personal care homes in the fire safety codes are homes. They're residential facilities, and some of the larger assisted living facilities clearly are not the same as residential buildings. They're closer to a nursing home facility in size and construction. And so one of the problems is that an assisted living facility is prohibited from keeping just but a very few number of non-ambulatory residents, and that's been one of the issues. And so what this bill tries to accomplish is if a resident doesn't need a nursing home level of care, but is non-ambulatory, they ought to be able to stay where they are until they do need nursing home care. And that was one of the goals of this, is to try and figure out a way, not necessarily around the fire safety code requirements, but to try and incorporate what those fire safety code requirements are, and allow a facility that has the construction and the staff that's closer to an actual nursing home or other type of healthcare facility to benefit from that classification, so that people can stay there longer, and that is a function of their own ability, the ability of the staff to get them out in case of an emergency, and also the actual construction of the building. The other thing that I'll add real quickly that this bill tries to accomplish is to allow now called assisted living communities under this legislation to employ certified nurse aides who go and get special training on medications to then become what are called certified medication aides. Now there would be a regulatory process for the department to certify CNAs to become medication aides, and then they would get training, and then they could give medications directly to individuals in the assisted living community, which they can't do right now. Right now it's set up so that if a resident needs medication, he's either got to take it himself, can get minimal assistance with taking it himself, or have home health come in and administer the medications. This would allow a new classification of medication aides to take care of that.
So occasionally before, if they were losing their sight but weren't totally blind, but maybe couldn't read the bottles, they could have been forced to move on to a nursing home because they couldn't self-administer.
Well, I think someone could read the bottle to them, but let's say they had Parkinson's maybe. I don't know if that's a good example or not, but they physically could not take the pill out of the bottle and put it in their own mouth. Well, a personal care home right now, under the DCH regulations, wouldn't be allowed to do anything other than sort of set it out there and hope for the best. And this would allow essentially a CNA to administer the medication. As long as this person doesn't, need what is already defined in the regulations, continuous medical or nursing care, which is essentially skilled nursing care.
Questions for? Oh, Representative Henson.
I think you addressed it, the Parkinson's, because it could also apply to someone who has bad arthritis.
Right. Who couldn't get?
And who couldn't get bottles open or get the pills dispenser opened or be able to ensure that the pills would be able to go from their hand to their mouth. So I like that.
Right.
I mean, because in all respects, they don't need to be in a nursing home. They're really perfectly capable of either being at home or in a personal care home or assisted living.
Right.
And
I'll tell you,
thank you for addressing that.
yes, ma'am. One of the things is that when the two sides actually did start discussing this with each other, went back and said, we want to work together, and I'm coming from the Georgia Healthcare Association side, but I certainly do represent assisted living facilities now as well. But what is it that you need? And some of the discussion last year was that, well, you can't have hospice in a personal care home. Well, you certainly can. You can't have home health in a personal care home. Well, you can. But what is it that you need to get done for your residents? And those are the two big things. We're worried about residents who don't need nursing homes but can't get around anymore. Let them stay a little bit longer. And again, that goes to the fire safety code, essentially. And the other issue is this ability to take medicine themselves. If they can't and they need just a little extra help, then that's how to take care of that. And I think those are probably the big issues. I know that there may be other things in the future, but I think this accomplishes the big goal.
Okay, we seem to be starting with a lot of beginnings. Representative Hudson.
Two final questions.
Okay.
On the training for the medication aids, has that program already been established? Is it available for somebody to be trained now?
It's not.
It's not established.
Well, I tell you what is established, and I can't profess to know a lot about it. There is a statute from about, I think it's 2 years ago, for qualified medication aids. That's established, and my understanding that there's been one person in the state of Georgia to go through that. So, and I think that sunsets this year, actually. Right. So the idea would be, I would imagine that it would be similar to that, but the statute leads it up to the department.
It is available, though?
No.
It's not available.
The two people that were talked about doing this are the same people that developed the qualified medication aid program from 2 years ago. But this kind of incentivizes more people to apply for it. 2 people ultimately passed the exam. 1 left the state. 1's still here, like you mentioned. So it's very similar.
And the people that brought this to the table their intention was to model it on a program in North Carolina that apparently has been very successful.
One final question. Have we made the state fire marshal happy with what we've put in this bill?
I can't speak to that.
Okay.
Don't know.
Okay.
I mean, specifically, it says that this assisted self-preservation has to get to a designated point of safety within an established period of time as determined by the Office of the Fire Safety Commissioner. So, I mean, that person sets that time frame. Either you do or you don't. So I would think as long as you meet the regs that they have in place, that they would be happy. And so it doesn't ask for a waiver from those rules at all. It says you shall meet. It doesn't say you may. I can play it back on the may or shall that you had discussed earlier, but it says you shall get to a place, an established place.
Does anyone else want to speak on the bill? Oh, all right.
Thank you, ma'am.
Thank you. Mm-hmm. And you were much better than last year. You're a keeper.
Madam Chairman, Tom Bauer with the Aging Services of Georgia. We represent mostly nonprofits who provide a continuum of services and senior services. And really not prepared to speak to the bill one way or the other, but just to point out that we were one of the groups that Chairman Martin mentioned that contributed to his 3 files there and the input last year. We really have not seen this bill until it was dropped in. I have some questions which some things I think may very well be, hopefully, unintended consequences, but could be significant, including, in fact, on the proxy caregiver legislation that you worked on so much last year. Having said that, we are talking with the Alpha folks tomorrow morning, but I didn't want to be, I try to be as upfront as I can. Wanted to let the committee know that there are some questions. I'm hoping I will get them answered tomorrow. Just kind of wondering if we can address those as we go along.
Just make sure that you also include the
Absolutely. Well, we'll be talking
other
to them.
side.
Yeah, I don't know if they're talking on the call tomorrow or not, but I'll be happy to talk to anybody.
Probably be good for everybody to be on the call, please. I don't want any.
Madam Chair, if I may, we've waited, Tom, for this to get to a compromise. I think there's not a lot of time, so I would encourage everybody to be very inclusive. We're not
in the discussions.
This committee wants to understand what all sides are, so I would.
Let me say unequivocally that my group has been one of those groups for 16 years that has wanted this new level of and having people age in place. So we're not in any way trying to derail, but I would like to get some questions answered.
And I think that what I would say to you, as I said in the beginning, this is not going to take care of things for everybody. And probably Steve Neff is waiting to say things. It's a beginning.
Yes, ma'am. Thank
after
you.
16 years. So if it's technical, and I would like everybody in on the discussions from both sides, please.
Absolutely.
If it's technical, I'm okay with it. If it gets more involved because it's expansive,
Thank you. And if I had not been involved with the other earthquake legislation that got the trial lawyers and the PAs and the nurses together, I perhaps would have had an extra day or something to get these questions answered.
Okay,
thank you.
Steve?
Yes, ma'am.
You want to be the last voice?
Yes, ma'am.
Okay, sorry.
Madam Chair, members of the committee, my name is Steve Neff. I represent the Assisted Living Association as well as the Georgia Association of Community Care Providers. We have also worked with Chuck Martin in previous years with the chairwoman as well. My two groups only saw the current piece of legislation as of when it was dropped, so they have not developed a position. Officially, I did want to let the committee know that we have had some discussions with the nursing home and with the Alpha Group and with Chairman Martin about that Section 13, and they have been open to discuss that with us further. And we do have some concerns about how that might affect the implementation of House Bill 1040, and they've been very open to have those discussions with us. So we look forward to moving forward with that.
Okay, and I know that you serve different communities, and
yes, ma'am.
Like I say, I know their concerns, and we may not hit every community. And I know that you and somebody very dear to us, it's gone.
Yes, ma'am. Ms. Freddie Hagan. I've worked many years on this legislation.
Yeah.
Thank you.
Freddie Hagan.
Appreciate the
opportunity. Who all of us that have been here for a while know. And we may not solve all the problems or get everything we want this time, but, yes, we're not going to forget you. I mean, we got a ways to go. We have to start somewhere.
Yes, ma'am. We appreciate the opportunity to be at the table. Thank you very much.
Okay. Others that want to speak on the bill?
I'm Kathy Floyd with AARP. Just wanted to kind of bring consumers into the equation.
Great.
And appreciate Representative Martin's hard work on this and your commitment to this bill. We have got several questions for Alpha about little parts, but we're very happy to see this come forward, and the compromise we appreciate. We have heard from quite a few members that are very frustrated with the waiver process and what they've gone through. Been calling me. They want to come down. They want to talk to you. So we're very excited to see this legislation. We do realize that it's going to be just for private pay. So this legislation just addresses the private pay part of it. So we understand that compromise. Thank you.
And what you're taking about the waivers, it's so somebody could stay in where they were longer. Does this seem, I know you have some questions, but basically this seems to take care of most of the people who are asking for those waivers because they can't get their medicine or they need to use a walker.
Right.
All right.
Right.
It does seem to take care of.
The 90% of the people I've heard from are over the ambulatory issue. So, being able to get transfer in and out. So this does, the self-preservation does seem to address that issue.
It's a good day when we can address 90% of an issue from people who are wanting that. Okay, thank you very much. Just make sure everybody's included in the discussions. It's not just one side. Fran, any discussions, make sure it's on both sides.
I'm Catherine Fowler, Director of the Georgia Council on Aging, and again, representing consumers, which have been at the table for years and years. And we are very much dedicated to not being in a corner fighting things that are going on. We're excited that the industry, the two sides of the industry, have been able to come together this year and get a compromise that gives us a way to start. We certainly acknowledge it's a start. It does get 90% of the people, as you all know from looking at it. It's not tackling the folks who are in the smaller homes or the folks who get Medicaid, and that's for another day. We did just see it in its entirety yesterday, and are in particular trying to check a little bit with the attorneys who can help us make certain that the folks who are in the smaller homes aren't in any way going to be affected by it. Just sort of looking at the department's rules and so forth to double check that. So we appreciate the opportunity to be involved in the discussions and hammer out some questions that we've got. Thank you for your work on this.
Well, and I have to thank Chuck for persevering and driving us all a little bit nuts over it, and sometimes that's what it takes to make you move on an issue. And finally, and to the new members of the committee, they're really lucky that they weren't here last year as we went through this, and it's much better when we can bring sides together and there can reach compromise that works for the betterment of Georgia citizens, and I think this is what this has done. Is there anything else? Anything else, Representative Martin?
No, Madam Chairman, I just thank you again, and for those that went through the long hearings with us last year, and we are at a little bit of a different place. Don't think that work didn't make a difference last year. I think without every piece of it, without every question, whether they were, friendly or not, right. I think it went into making what we are today, and I appreciate that. I think Georgia will be better off for it. I do sincerely thank you all, and hope I can help make this happen before I'm in need of one.
And I coming soon for both of us.
Madam Chair, I will be a card-carrying member of a senior organization in July of this year.
You could have gone without saying that. I've been a member for quite a while. Thank you so much. To the members of the committee stayed, thank you very much. Monday should not run anywhere this long, probably about an hour. Thank you, but I do need to get you here. Thanks. We're adjourned.